to be a board member from my colleagues, and today we are having the session with under the title of the current state of the quality assurance and specialty addiction studies programs, and I'm having senior members from our field to present. The presentation will be on a sequence directly starting from Dr. Dennis McCarty and by our future good candidate, Jordan. Mr. Jordan, who is working now on the same time, who had the presentation this morning, and finalizing our presentation with Dr. Victor. I'll give a brief about one of them because unfortunately, if I'll be talking about their bios, I'll be taking the session from them. We have a senior member, so Dennis, he worked on the intersection of policy, research, and practice, assessing the organization, financing, and the quality of prevention and treatment services for alcohol and drug use disorders. He worked on the quality of care beginning since 1989 as the Director of Substance Abuse Services for the Massachusetts Department of Public Health, and the formation of quality improvement collaboration. Dr. McCarty have got a lot of work being done on that line. This will be after the session of Dr. McCarty immediately. Our friend, Mr. Turner, Jordan Turner, and he's an MBH student at George Mason University at the current time with concentration in epidemiology. And he is working on experience on research assistant for same university in the laboratory and non-profit organization dealing with homeless and marginal people, programs internationals. One of his own work is increasing, one of his own concentration is increasing effort and directing towards health in low-income countries. So Mr. Jordan will be following him up. And finally, we'll be finalizing our talk with Dr. Victor Capoccia. Dr. Victor is a PhD with over 40 years of experience in management, policy, research, and consulting practice. And he's looking to improve the access to quality and prevention treatment programs and recovery support for people and families with substance use. Dr. Capoccia work and improve the quality of and access to addiction treatment beginning in mid-80s, where when he was the director for the City of Boston Health Department of HIV and AIDS, beginning in primary transmission via shared needle use programs among drug dependents. He has also been involved in speaking and consultation internationally with international UN organizations like UNODC in Vietnam, Russia, Serbia, and nationally with the SAMHSA, Ohio, ATCC Center for Excellence, and many other programs that have been involved with. So I'll keep the floor for our professors and senior people to learn from them. And once they will do the presentation consequently, and then we'll be starting having the question from you consequently. Thanks a lot.
Thank you. I've had the opportunity to spend some time here the past week. We came a little bit early to time adjusted and to enjoy the Chiang Mai and the surrounding rural communities. It's been a fascinating journey. I thank all of you for supporting, for being here, for joining us, and for listening to this session. This is the second plenary session. The first plenary session this morning examined drug demand and the changing nature of drug demand, and point out the needs that, at least to me, they point out the needs for treatment programs to change, treatment and prevention programs to change in response to changing markets, changing environments. And that's going to be a major facet of our discussion about quality and quality improvement. How do programs adapt? How do programs change? How do programs mature and begin using different technologies and different strategies to better address the changing nature of the drug and alcohol epidemics that we encounter? My role is to provide the introduction to this presentation. Jordan will provide results and methods, and Dr. Capoccia will provide the conclusions, and we encourage next steps. This is a study that ICUDDR initiated and anticipated in anticipation of this meeting. There were questions about how does the membership of ICUDDR address the quality of the services that treat and prevent alcohol and drug use disorders. How does the membership address quality? How does the membership address the process of quality improvement? So we're going to share the results of that survey. These are our disclosures. It's an outline of the supports that we have for our work that we do, and it also assures you that there's no conflicts of interest. We're going to look at quality standards, quality improvement strategies. We're going to review the World Health Organization and the United Nations Office on Drugs and Crimes standards. We're also going to assess, compare that to the Institute of Medicine standards from the United States. We're going to report the membership survey and the findings that we made, and more generally discuss the role of quality standards and quality improvement. This is another reiteration of those outlines. Quality of care is important. Quality improvement is more important. Every patient deserves appropriate care that achieves its goals. We also recognize that perhaps 10% to maybe 20% of the people who need care actually receive care. And the United Nations Office on Drugs and Crime, the World Health Organization, the National Health Service, the Institute of Medicine recognizes that systems, policies, interventions are designed to help patients manage their health. So these are critical standards, but in many ways they're meaningless sentences. The meaning is the people who are seeking care. For me, I have a face to put to these standards. It's a man I met on a flight from Kansas City, Missouri to St. Louis, Missouri. It was a short flight. It was one of those airplane conversations that we usually forget quickly. The woman in the seat next to me said, saw me reading professional journals, said, "What do you do?" I told her, I study the organization and financing of care for treatment of alcohol and drug use disorders. That's usually sufficient to inhibit conversation. In this case, she asked some follow-up questions, and I found myself talking about the work that we've been doing to help programs be more efficient so that they can treat more patients, to help programs address early dropout, retention and care. How can you improve retention and care? How can we improve the equity of services? How can we assure that both men and women, adolescents and adults, people of racial and ethnic minorities are receiving appropriate care? It was a short flight. As we began to touch down in St. Louis, the man reached over to hand me a coin and said, "Thank you. I wanted you to know." In my hand was his sobriety medallion. In the bronze was stamped 2 years of sobriety. He explained, "I went into treatment 6 years ago, but I wasn't ready to stop drinking." We shook hands, we went our separate ways, but his words, "I wasn't ready to stop drinking," lingered in my mind. He was blaming himself for not stopping drinking. He was blaming himself for 4 more years of use, of potential problems, of family strife, unemployment. He blamed himself. And it echoes what I hear from many treatment programs. The program with the waiting list tells me, "We use the waiting list to make sure patients are motivated for care." The patient who calls and says he needs care but doesn't come back next week, that's not motivation. We want motivated patients. I hear programs say, people who use in our program are discharged. They're not ready for treatment. That's the easy work. It's easy to work with patients who are ready. The real job of treatment programs is to work with the patient who isn't ready. And that's what quality improvement is about. How do we make our system be more responsive to people who are not ready? How do we engage them in care? How do we retain them in care? How do we create a system of care that supports men and women as they return to use? Return to use is part of the problem, part of the behavior that we're treating. We should expect it, not prohibit it. So that's the face I have for quality improvement. In the dark ink here, the black ink, are the standards that the World Health Organization, the United Nations Office on Drugs and Crime has promulgated for quality of care. In the blue are the 6 dimensions of quality and quality of health care that the Institute of Medicine in the US has used as a foundation for building quality systems. So care should obviously be available, accessible, attractive, appropriate. And under the IOM dimensions of care, it addresses timeliness. The patient who waits for care isn't getting care. The patient who's not getting treatment is not getting effective care. The patient who isn't getting medication for an opioid use disorder is not getting effective treatment. The patient who isn't age eligible because they're too young or too old is not getting equitable treatment. We want to ensure ethical standards of care. Care should be safe, care should be equitable. We're promoting coordination. Care should be patient-centered, efficient, effective. Care should be based on science and respond to the needs. Again, patient-centered and effective care. We need to respond to the special treatment needs of women, of pregnant women, of adolescents, of elders. Care needs to be patient-centered, care needs to be equitable. We need to ensure good clinical governance. Care needs to be safe, it needs to be efficient. And services and policies should be integrated. And that's all 6 dimensions. Quality care is safe, it's effective, it's patient-centered, it's timely, it's efficient, and it's equitable. These were the 6 dimensions that we surveyed. We want to know, we asked, what are ICUDD members doing to teach their students, their learners, that care is safe, that care is effective, that care is patient-centered, that care is timely, efficient, and equitable. How are we reaching? How is that message getting out to treatment programs and the providers who will be working and building in those treatment programs in the future? That's the question we were asking. We were also asking about quality improvement strategies. Which of our programs are using methods to understand patient experience? How do we understand patient experience? How do we understand continuous improvement? What is continuous improvement? How do we measure, track, and report our outcomes? Are we assessing outcomes? And what kinds of systems are we talking about? What kinds of systems change are we proposing, and how do we go about doing that? That's the context for the survey, for the ICUDDR membership survey that we conducted this summer. Jordan, tell us about the methods and how it works.
All right, thank you, Dennis. So for our methods of data collection, we included a 31-item survey. Next slide. A 31-item survey collecting information from 322 ICUDDR members in the summer of 2023. The survey was designed to assess the efforts of training students in the quality care improvement. And the survey content included identifying information from the key informants, students enrolled in certificate, bachelor, master's, and postmaster's programs. And then content on quality care, whether or not they met these standards, as well as quality improvement. And then we also talked about, we want to get information on whether or not they address future plans for assessment. So looking at our first table, based on the survey results, we created 5 tables. The first one has the ICUDDR member responses by continent. As you can see, we had information from 5 different continents across 38 countries, with African countries having the highest response rates, followed by Asian, North American, South American, and then European countries. Table 2 shows a summary of the number of students and programs for each level of education. The table shows that 2/3 of the members reported having training programs, with a little under 10,000 students across 39 certificate programs, around 29,000 students across the 28 bachelor programs. We have 2,800 students across 34 master's programs, and then a little over 1,000 students across postmaster's programs. So our third table displays the number of members addressing quality improvement and the dimensions of quality care that Dennis had talked about. 63% of these members reported curriculum addressing quality care, and the percentages of the 6 aims were around 59% to 78%, which can be seen in the last column of our table. And then one thing to note is that for tables 3 and 4, we collected qualitative data, which was asking participants to describe their curricula and then addressing quality care and quality improvement. And I wanted to point out that a lot of the written responses weren't helpful in assessing the programs, but this leads to a question of how can we strengthen quality data collection process in the future. Table 4, in our next table, you can see the number of members that reported addressing the 4 elements of quality improvement. And then across the 4 elements, percentages of training programs that discuss quality improvement range from 43% to 59%. And then table 5 displays future plans for ICUDDR members to address quality care and quality improvement. So data shows that 22% of the total responses, or 19 members, have future plans of addressing quality care in their curriculum. And in addition, 25%, or a total of 25 members, have future plans of addressing quality improvement in their curriculum. And then collecting qualitative data from these members, there was an interest in adding some of this quality content, but there was a need for ICUDDR to kind of give guidance on the next steps and how to improve. So I'll pass controls off to Victor.
This is going a lot quicker than I thought. I'm really going to talk for a long time, or you're going to have time for a break and questions and discussion. We hope, actually, that I don't talk for a long time. We hope that you have lots of questions for discussion. Dennis, I think, set the context really well, particularly drawing on the information from this morning's presentation around the availability of drugs and the ratio of people who need treatment but do not get it. One out of 10, or 1 out of 7, 1 out of 5. It's in that range, and we've made reference to actually all 3 of those numbers over the course of the morning. But what that also doesn't say is for the people that 1 out of either 5, 7, or 10, that in their treatment engagement to begin with, usually only 1 out of 3 stays with it to have some kinds of results. Now, it might be multiple times, and that number may go up over time, but generally we're talking about 1/3 of 1/5 or 1/7 of people who need it. So overall, I have to say, that ain't a good record. It kind of leaves us to saying, okay, let's look at the data that Jordan just reported on. And I'm going to just say outright, those that know me know that I will just kind of say things that's on my mind. And sort of what's on my mind is there are 380 some odd members of ICDU. We got 88 responses. So one of the things we really want to discuss and get ideas from you is, how come? What's that response rate about? The second thing, the implication of that number that we started with in terms of what the challenge is for treatment and for quality treatment is the, I'm sorry, I lost the train of thought. No, yeah. I know I'm on, okay. Is that, okay, what was the response rate? The second thing is that if you go through the data that Jordan just presented, it's in the 40% range of the programs that did respond that said that they're really doing something around either those quality standards or quality improvement processes. So there's work, so in effect, there's work to be done. This isn't to say that the work that's being done in academic programs training people to work in this field is wrong. In fact, my instinct, and I think the evidence shows, that you know what evidence-based practices are. I think you know what the ideology of psychosocial origins of biopsychosocial origins of addiction are. I think you're probably very effective at communicating that and helping young people or students learn or adults learn to be able to apply those in an effective way. So what's the barrier? We actually heard several references to that barrier in presentations earlier today. Mr. Hoffman spoke quite a bit about the importance about advocacy, system change, and policy. We heard examples in other presentations, or I did in the presentations I listened to, I think, in particular, how the context in which an individual treatment relationship exists is affected by the system. What do we mean by that? By how is it financed? Who owns it? What are the policy contexts that it operates in? The rules that, what are actually the operating procedures? What hours does it open? What hours does it close? What's a caseload like? What's a supervision process like? Those are working procedures and processes. They can either impede the use and delivery of an evidence-based practice or support it and promote it. And I think what we do not have on the third leg of a stool, we have knowledge about etiology and we teach that. We have knowledge about the evidence-based practices and we teach those. I'm not sure from the survey results, and again, our discussion afterwards hopefully will expand on this. I'm not sure from the survey results that we are using the knowledge that we have about systems, system development, changing and improving systems. So we're not going to try and say, here's a curriculum you should have. In fact, in the last session on innovative programs for substance use training and education, there was just before lunch, the last question in that session was a question that had to do with, are there ways to standardize curriculum within a country context? And I think that the response to that question was collaboration and coming together, and I think that's accurate. But what occurred to me is we have a basis for developing a reasonable curriculum around quality. The UN standards, the IOM standards, are that. What they represent is a collaborative, collective gathering of knowledge, a consensus of what works. And they're spelled out in a set of principles. It seems to me that it's reasonable to begin to build curriculum around those principles, and that could be something that's quite standardized. So while we didn't try to develop a whole curriculum, what we did think about, what is it that you want the person to know? What are the learning objectives? And so that led us to this list. Understanding the patient's experience, which we've had several references to. Dennis has talked about that. And there's a lot of ways of doing that. One of the other presentations in the before lunch session on innovative practices or innovative programs made references to university walkthroughs. And in my head, again, I sort of jumped up and down with that because the walkthrough concept is one that says, I'm going to put myself in the position of understanding what the customer experience is. What's the patient experience? When I was introduced, it was reference to a program I ran. I used to call that program from time to time. Not anonymous me, I'd say who I was. They knew who I was. And it was multiple programs, so you'd call it detoxification withdrawal management program or an outpatient program or medication program, what have you. Because I wanted to know, what are people experiencing? Who's answering the phone? Is it being answered? How many times does it have to ring? Do you put it on hold? One of the things we found out from that was that as the number changed and the system changed, We had numbers that were public that went into endless loops. We didn't even know it. But that's experiencing what the patient does. That's walking in their shoes. It's a walkthrough. Know the basic evidence-based approaches. Those are the standards. Understand the impact of difference overall. Understand the impact of system design. And that's what I emphasized a minute ago. What was the financing like? What is the structural relationships of authority like? What are the collaborative relationships like that make for complementary services? That's the system design dimensions. Understand the role of measuring, tracking, and reporting. If we don't have ways in data systems that focus on what is happening with a patient or patients collectively in our organization over time, how do we know? We could say we think things are getting better, but better isn't a measure. More isn't a number. You want to have data systems, and we want our learners, who are going to become the professionals, to understand how to put a data system together, how to use a report, and then how to draw from that to make change. And then the last, obviously, is how do you make change? And how do you begin to evaluate results? So there's only 2 slides. I'll stop in a minute. So looking ahead to the learning organizations, that's you, the universities, the academic centers. What are some of the things that, from the work that we did in this study, you might want to think about? One, you might look at what are the quality standards for treatment that exist within your context. Are there government licensing standards? Are there government other treatment standards? Are there oversight processes? Are there funding organizations, criteria, or standards that you might want to begin to think about that are related to quality? And if they're not, then within your particular immediate context, are they available in your region? What are the faculty or community resources that have expertise around these areas that you can look to? Do you have faculty within your programs, not only who understand the elements of an evidence-based practice, but that whole set of standards? Do you have faculty expertise in your programs that know about change theory, system theory? One of the things I'd suggest and ask, has anyone gone to any university, talked to their School of Industrial Engineering? They know more about quality improvement than probably most of us in this room, all of us, maybe together, because that's one of the things that they do. They take systems apart, they put systems back together in ways that meet the standards Dennis was talking about, that are more efficient, that are more effective, that are fairer, that are ultimately get the result that they're intended and designed to do. What collaborative international entities and experiences might you draw on as a resource? What kinds of internships, field experiences might you place students in so that they have some practice-based learning opportunities around improvement approaches? Again, one of the things we did early on in a treatment program that wasn't one I was responsible for, I don't believe we were very responsive in the way that we should be to people who were calling for admissions. And we tried to put together a work group to say, how do we improve it? And frankly, we didn't get very far. There was in the Boston area at that point, one of the national, international organizations that was working to improve the quality of healthcare writ large, hospitals in particular, called the Institute for Healthcare Improvement. I called them and said, would you help us with this small substance use treatment program? You talk about institutional and systemic differentiation. They said, no, we want to deal with hospitals. We don't want to deal with you all and this behavioral health stuff. Okay. I called Marriott hotels because at the time, if you walked into a Marriott hotel, you didn't have to walk in. There was someone at the door that opened it for you. There was someone that greeted you. There was someone that said, can we help you? Where can we point you to? There was someone that said, you're here for us, we're here for you, what do you need? We're going to respond to it. We were impressed with that. And by the way, the Marriott Hotel sent their human resource person to us, and we had a work group within our organization, and they worked with this human resource person to help develop staff to be oriented to patient needs, in the same way that Marriott was being responsive to the customers that walked in. Finally, practice what you teach. If we're going to be teaching about quality improvement, how do you model that in the way you operate the programs for your students in the curriculum and all? And finally, we had some thoughts for the organization writ large. First one is the one that I mentioned earlier on. We can have some discussion, hopefully, about the response rate to the survey. It might be interesting for ICUDDR to gather some curriculums and do some actual content analysis across the regions that we summarized. There are international stakeholders, as Dennis referenced in the reasons for focusing on this: UNODC, WHO, INL, ICUDDR. There's a strong focus on quality improvement. Some of you in your countries may have had the UNODC training around the standards for policy. And this can be supported. This shouldn't go away. And so you have the opportunity as academic institutions feeding the workforce to have people well prepared in this area. So getting the international organizations that are leading this initiative now involved is important for that's an ICDU role. It'd be interesting if you want to create a quality content curriculum work group to begin pulling some of this together, looking at the environment for model curriculum, developing, refining the learning objectives, etc. And it would be interesting in 2 years from now to do this survey again to see if there has been any changes. So I want to thank you for your attention. I want to thank you for responding, those of you that responded, and those of you that maybe it just went to the wrong email address or people are busy. But anyway, thank you for your attention. Let's look forward to some discussion and questions. There is the reference.
Okay, thanks a lot for our distinguished guest, and I'm sure that so many of us, while they are talking, are thinking somewhere else, in our centers, in our places, and what are we applying whatever being said or not. So we'll open the question. We have plenty of time, so let's start. Yeah, please, from the to the right. Do you need a mic? You'll take this one or the other one? Yeah.
Oh, sure.
Hi there, and thanks for the presentation. And I did respond, but we work in prevention, And there's a whole group of us who couldn't answer many of the questions. They didn't apply. And I continued on and continued on as it got closer and closer. And then I thought about, well, maybe I shouldn't be responding. But then I did anyway.
Thank you for responding.
Right, can we just introduce each other before, once you get the question, introduce yourself from organization you are in, so we can know at least each other.
Thank you.
Thank
I'm
you.
Sue Ellen Crano from Claremont Graduate University.
So Dimitri, and then you'll be Prof over here. Yeah, you'll be after him.
So my name is Dmitry Krupchanka. I'm from WHO headquarters. And I spent 4 years of my life developing with UNODC the standards that you presented. And we in WHO did a field testing of them before revising in 9 countries. And guess what? So we assessed utility, comprehensiveness, accessibility, adaptability, and feasibility. And guess what? The most problematic part was feasibility. So the countries where we did field testing, they asked many also qualitative comments that that's all sounds nice, but please help us. We don't know how to make this work, how to implement these standards and qualities in practice. So that's why, together with UNODC, we are now working on the implementation toolkit for the standards. And I would be grateful to follow up discussion and to hear more thoughts on what you think should be in this tool, and also learn from other colleagues in the room. Then I wanted also to mention many things that, Victor, you said, reflect also the thinking that we in WHO have, particularly on monitoring of health system, because standards is not only about education, it's about financing, about access to medicines, about governance, about guidelines, about so many things, legislation, finances. And we are doing WHO global survey on SDG target 3.5 in all member states. It's like a focal point in ministry. We collected data from 150 countries, did imputation to 180, and like in about 1 month or 2, we will release data on the global service capacity for all the countries, and then there will be opportunity to look into all individual indicators. There are 300 different indicators. And so our hope, and actually the thinking about the standards, that there is no one simple solution. So countries different. And there's, before any work on improving quality, we need to see what is missing in the country. So if there is no local proper legislation addressing confidentiality, how we can even further work on improving treatment services and many other things. And finally, sorry, I say too many things, but I have presentation tomorrow with UNODC on international standards and on the service capacity that I'm mentioning. And then later in Plenary 4, we want to speak about the new project we are starting now, core competency framework for pre-service education and postgraduate education on mental health and substance use. And the main reason why I'm here in this ICUDDR conference is to hear from universities who are present here, what are your challenges? What is your experience? Tell us what we need to have in this core competencies framework. And I think what Victor said, that's very timely, that we pay attention to not just doing more trainings, but thinking how we can standardize, how we can make sure that we all mean same things when we do all these trainings. So that's just a comment. I could continue, but I hope we can follow up with discussions.
Thanks, commentary. Any feedback from your side?
Thank you for those comments. And it was actually the UNINL, this international initiative, that drove us to think about doing the study. And we had been part of that, heard about it, was part of it. And when it came to thinking of training people who are going to be professionals in this field in one form or another, the inclusion of the system dimension that would actually improve. I'm not totally surprised by the results that we saw. As I said in the presentation, I think You know, and I think this is about practitioners as well. They're not dumb people. They're smart. They're committed people. And evidence-based practices, they know what they are. They may not be able to replicate them exactly. They can help, but once they're in the field, they begin to know where they are. Why? Because you've taught them that. They know the origins of addiction. Why? Because you've taught them that. What they don't know is how to deal with the systems that they're working in. They don't know, in terms of even the managers and policymakers, how to put those systems together, how to link them so that there is patient movement and flow that is supported among different institutions. I think the one thing I want to also just emphasize from your comment is we need to understand and treat differently. We need to treat them together, but they're different notions, that of quality and teaching what is quality treatment as opposed to quality assurance, which is looking at what you're doing, as opposed to quality improvement, which is making change. So there's really three different dimensions that need to be addressed.
Yeah, and just to amplify, the implementation is the hardest thing, the feasibility. And this resource, NIATEX, the Network for the Improvement of Addictions Treatment, addresses the feasibility question. How do we do this in this agency today with this patient? Start with one patient. You're not changing your entire system of care. Let's try it with one patient. Keep it simple. So they've been a great resource. They've had a major influence on behavioral health services in the US. They can help you as well. Next question, please.
Good afternoon. I'm Gavin Bart from Hennepin Healthcare, University of Minnesota in the United States. I know a sample size of 88 is small to work with, but you had 5 continents. You assuredly had wealthy nations, low middle income nations represented, nations with nationalized health systems and non-nationalized health systems, maybe addiction training programs that were in schools of social work versus schools of public health versus medical. Any signals in your data to explain the spread and where they're, to help focus where maybe efforts in quality assurance, quality improvement should be guided?
Thank you. Were there any differences that we could discern between the kinds of responses we were getting? The first thing we looked at was, do undergraduate programs differ from professional programs? Or for graduate level programs, for physician training? We couldn't see it, not in the responses that we got. Now, some of that was, how did we articulate the questions?
We own some of it.
So we own it. This was done under short timelines, rapid development. It could be better. The next survey will be better. With prevention programs, yes, we overlooked prevention. We apologize. It's a different set of questions. What else, Victor? Yeah, it was hard to see any differences.
We saw the differences in continental. I mean, why didn't we get any responses or barely from the US given the number of programs? I don't know. Why didn't we get any from Europe? I don't know. The concentration from Africa, I met the ICDU person from Africa, and I said to her today, what a great job. You must have done recruiting people to, encouraging people to respond, or maybe they responded themselves. I don't know how it happened, but there were those differences that we can't explain. I don't know.
Thank you. Michael?
Yeah, Michael Miowski from Prague Charles University. Guys, first of all, thank you for opening this this issue and taking it here. And sorry, that's a shame that from Europe we have only 9 responses, as I saw. And exactly that's the issue what we are dealing with in my team. And after 20 years, and we are probably the biggest educator in Europe with 300 students in bachelor, master, and PhD program on addictions. And we are dealing with it, and we are trying to find how to train students in this issue. And I found that it's theoretically too difficult, especially for bachelor students. It's so huge and it's so complicated that the major issue is how to train it. And in our team, we have a discussion now what we need to change, because again, after 20 years, we are trying to improve something, and I see that we are not enough effective in training and understanding to quality. And the turning point in our discussion was dealing with clinical guidelines, because it needs to be very practical, and you know, we have no space, enough space for teaching and explaining everything to students, because we are preparing practitioners, people for praxis, not theoretical-oriented people. And these people are prepared for face-to-face working with patients. And my understanding, my plan, and result from our discussion is that we need to base our training on working with clinical guidelines and train students on it, because it is more practical, it's more understandable for students. And these issues, what are broader, what are more theoretical, we will leave it for postgraduate students and for more theoretical people who are interested in these issues. But for younger students, especially in bachelor and master students, we have decided to move on and be more concentrated on clinical guidelines and train students with the clinical guidelines. And my question is very simple. We found that there is huge imbalance and problem with clinical guidelines in different areas of our field, because we are training in prevention, in harm reduction, in treatment and recovery, and we are mixing all this area together in our curriculum. But the problem is that we can find many clinical guidelines, highly quality clinical guidelines for treatment, especially for particle methods. But in harm reduction, in prevention, and in recovery, we have very little evidence, and we have very poor clinical guidelines in that area. And I don't know what to do with this imbalance. And my question, if you have some recipe, some ideas, what we can do in this matter, or we can start somewhere and speak about it and share this problem, I don't know.
Good question. Some of our programs that have embraced quality improvement more strongly, more vigorously, have found that they need to turn over staff. The staff they have is not the staff they need. You need different people to really do a quality improvement perspective. They say, well, we can't afford that. Well, you can't afford not to. You know, if you're going to survive and move and grow, you may have to change some of the people you work with. That's a hard prescription. I understand that. With training, it means we need to train them differently. And training in clinical guidelines is one of the steps. The other step I think that is so important, that is overlooked, is the training in data. Counselors say, I'm here to talk to people, not to collect data. But if they don't collect data, we don't know if they are helping patients. They think they're helping patients. We need to show that they're helping patients by collecting the data that shows that the patients are changing and improving. That's a hard part. That's another hard step. If it were easy, we would have done it. So it's a good challenge. It's a challenge that we embrace. Victor?
So I heard the question really have two parts. One, you were talking about you've got people with the clinical guidelines. You're good at that. You can do that. You know what they are. And I took from that also that that in saying that you're educating people and training people around known and established, proven clinical guidelines, that they don't necessarily have the room for looking at the quality improvement processes. I would argue that the frontline person should. Toyota is an example of an organization that makes a car that's a pretty reliable and long-lasting, etc. They empowered their frontline workers not only to do what they were supposed to do, but to make suggestions of how to do it better. And in some respects, I'd say, in your clinical outpatient department, in your residential program, in your your medication program, the person on the front line probably understands what the barriers are and what the opportunities to make it better are. The problem is that when they complain, we say if they fear, we operate in an authority structure that does not reward pointing out problems. It in fact punishes for pointing out problems and errors. And in fact, what we want to do is the inverse. I mean, this was the whole thing about hospital errors. And we make them in our field because healthcare is similar. That the healthcare errors get covered up, and part of what the Institute of Healthcare Improvement tried to do was to say, raise them up. That's what you want to work on to change so that they don't happen again. So I would argue that you need to teach the front line not only the clinical guidelines, but how to make the change and raise that as well. Second, relative to the prevention, harm reduction, those other areas that there aren't as clear guidelines, and how do you make improvements in that? Again, I'd go outside our field. Maybe, I'm not exactly sure how to do it, but I wouldn't hesitate to go out and, as I mentioned, talk to people in industrial engineering and saying, this is the kind of system we have. How would you approach that? And try to learn from some people from outside our field is the other dimension that I would suggest.
Thank you, doctor. So there is a question, Dr. Tarek, and then later on, yeah, lady over here.
Thank you very much. My name is Tarek Abdelgawad. I'm ICUDDR, a new board member, and thank you for that. But I'm professor of psychiatry, addiction psychiatry at Cairo University, Egypt. I had the privilege of working in one of the health service programs for drug addiction. My question is about how, in different parts of the world, each program have its own policy, procedure, strategy, and outcome. How we can measure different outcomes. That is, I haven't seen in the literature a unified definition for outcome. The reason for that is because the difference in the service delivery. Service delivery is merely chemical detoxification. Others are a kind of residential treatment. Another one is for rehabilitation. And very few can comprise all this, and they have their own definition of their outcome. Now, if I am going to implement the quality standard, how I can implement it in a definition, for a definition like outcome? Thank you.
Each of those programs needs a different outcome measure. The gold standard in our field is that brass medallion that the patient in recovery handed me. The number of days without drinking, the number of days without drug use. And yet, that's not a subtle measure. That's a very difficult measure. Quality improvement is subtle. Quality improvement is a little change every day. So we need different outcome measures. If my problem is that patients are leaving care too quickly, I begin to look at how do we extend retention and care? How do we hang on to the patients longer? How do we engage with patients? That's my measure for that problem. If my problem is a waiting list or people not showing up for appointments, an outpatient program, a big problem is often people not showing up to keep their appointment. What strategies can we use to improve the show rate? And that outcome is different. But all of those outcomes are incrementally contributing to that brass medallion, days without use. And I think it's also time for us to consider reductions in use. I think it's a good thing if a person is drinking a lot, who's now drinking a little. That's not a failure, that's a success. So to some extent, we need to redefine our measure of success as well. Those are my quick thoughts. Thank you.
Thanks a lot, Doctor. Just the final two questions, unless you will be aborting your break. So very quick, please. The lady over here, and then, yeah, and so three. So three, let's have them together so we can move ahead.
Go ahead.
Actually, I don't have a question. First, I just want to express my thanks to all of the authors of this. I look forward to reading the report in full details. Are you going to publish the report? One of my suggestions is to look at the HIV field internationally. I mean, I know that the HIV field, they have a HIPQO, HIV core, that a system quality of care and that have been sort of established in many parts of the world, and the curriculum, the training, and everything in there. And I think that the not just the curriculum, but also the implementation of the network to train and to monitor the quality is also very important. So I hope that ICUDDR and INL will support the future efforts internationally to push this area forward. Thank you.
Thanks. Yes, the report, we assume, we have prepared a more detailed report. That report is, ICUDDR has that report. We expect to get some feedback, make some modifications, and then I would anticipate that that report would be distributed to the membership. That's the reason for doing this. Thank you. Last question.
Hi, I'm Elizabeth Novakova from Charles University in Prague. I'm a colleague of Professor Majewski. And I would like, first, thank you for an amazing presentation and a great discussion. It's very inspiring and it made me happy. Thank you. And I would like to know your thoughts about the patient's experience, because we can try to walk in patients' shoes, and I know that NIATX made this great material that helps with the dropouts and lists. But how can we really hear the voice of the patients, of the clients, especially the vulnerable groups like pregnant women, refugees, homeless people? Because even for clinical guidelines, you need to hear the patient voice, and patients should be the part of the team when developing guidelines. So I would like to know your thoughts about it. And my second question is about this continuous improvement. How can we support facilities and services to adopt this thinking that it's needed to make this continual development? And you said that we can use some industry and engineering tools. And I would like to ask if you think some total quality management or Kaizen or other quality models can be feasible for this when you adapt it to our field, maybe. Thank you.
The first about the understanding the patient experience, I'm assuming you're asking that in terms of not an academic program, but a treatment program? Okay. By the way, in the recommendation for academic programs, thinking about the student experience and really understanding that is a useful tool as well. For the patient experience, you know, we use these patient feedback surveys. Usually, I think they're not worth too much more than their paper, because coming out, they feel that they have to check yes, 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 or coming out, they're feeling yes, yes, yes. And it's not telling you an awful lot other than their yes, yes, and maybe the food was not good. The example I gave, I mean, in a program, you can go through the experience that a patient does. When the NIATEX program that Dennis referenced, it's up there, that was funded from foundation. The application for the foundation first required the applicant to act in the role of a patient, go through their full admission process in whatever their program was, write it up, and do a critique of it. You can do that. You can act in the role. The person who designed that was an industrial engineer. He had himself admitted into a cardiac catheterization program because he was doing some work in that area, and he wanted to understand it. He did everything, including laying on the gurney, waiting in the hallway to get through. He did short of the surgery in order to fully understand. You can do that within your programs. You do it with full disclosure. You can do it with focus groups afterwards as well. You can do it with patient interest groups, in recovery support groups, because there's enough distance that you'll get. You can do it in a different way by watching and sitting with your frontline staff. So there's a lot of ways. The continuing improvement process, the ones that you referenced, yeah, they exist out there. And you absolutely total quality management, the work from the Healthcare Institute for Healthcare Improvement, they're there. Oh, time, we're time.
Well, thanks a lot. First of all, I'd like to thank our distinguished speakers over here who really keep us thinking, and thanks for all of you for coming and attending and commenting. There is a break, and I think the next session is at 3 sharp. Thank you.